Hey everybody, Ed Bowder from the Med School Medic podcast, medschoolmedic.com. We're back with another 5-minute EMS refresher, and today we're going to talk about continuous positive airway pressure, or CPAP. Now, CPAP is one of those tools that's really kind of helped us in EMS a lot. It's reduced the need for intubation, it's improved patient outcomes. It's not uncommon to hear EMS crews come in with a patient who's no longer sick in the ER, who's actually quite sick in the pre-hospital setting. You have a mask that goes on to this patient, it forms a nice tight seal around their mouth and their nose, and forces positive airway pressure into them, into their trachea and their lungs, while they're in the expiratory phase. Now that's important because it keeps their lower airways open with what we call positive end expiratory pressure, or PEEP. Now, PEEP is something that you acquire the first breath you take in life. Generally speaking, people have a PEEP of around 3 centimeters of water. Now, if someone's having trouble breathing, we want to prop that PEEP up to around 5 or 10 centimeters of water. You will see some CPAPs that have a PEEP of around 15. That's generally, I think, a little bit too high. You want to try and keep your PEEP between 5 and 10. Now, this works for patients who have asthma, chronic obstructive pulmonary disorder, congestive heart failure. We're going to talk about how that works now. Now, in front of you on the screen, you have a graphic representation of congestive heart failure, which in the broad scope of things is generally just water on the lungs. And to the other side, you have an asthma patient, a COPD patient, and what's actually happening with the inflammation in the bronchioles. Now, for congestive heart failure, you have a patient who has excess fluid sitting in their lungs, and what we want to do with CPAP is we want to take that positive airway pressure and force that fluid out of their lungs. Now, CHF is usually caused by left ventricular failure, right? So all of the blood and plasma that's trying to circulate through the body backs up into the lungs. There's nowhere else for it to go. So we take CPAP, we apply it to them, and we force all that fluid back out into the interstitial spaces around the lungs so that we can actually perfuse more oxygen at the alveolar level. With someone with COPD or asthma, you have this inflammation that occurs in the bronchiole. So for whatever infectious process or chronic process they have, the inner lumen of their bronchiole is essentially swollen shut. Now, what we do with CPAP is we apply this positive end expiratory pressure, and it props those bronchioles open. So it allows us to deliver more oxygen, the patient gets more O2 to their blood, and they tend to breathe better. And you're going to see an increase in pulse oximetry. You'll see a reduction in respiratory effort. So the goals, generally speaking, with applying CPAP, the first thing we want to do is we want to decrease the respiratory distress. That's the whole reason we're there in the first place. We have a patient who can't breathe, and we need to fix that problem. So after we apply CPAP, it's also going to increase their fraction of inspired oxygen. Now, the whole point in that, if we have a patient with COPD or who has CHF, the air that they breathe, it's not that the air around them is in a high oxygen concentration, it's just the oxygen that's trying to perfuse to the body is reduced because of that obstructive process in the lungs. So we want to keep an FiO2 close to 1. What the PEEP will do between 5 and 10 is, as I said, it's sort of going to prop the bronchioles open. So it'll take that space that's been reduced either from inflammation, swelling, or the fluid in the lungs in CHF, and it's going to either push the fluid out of the lungs back out into the interstitial space, or it's just going to prop the bronchioles open to allow more oxygen to get to the alveolar level, and then the patient can oxygenate better, and it tends to reduce the respiratory distress. Again, if someone has pulmonary edema through something like CHF, or even patients who have ARDS, this might be a good indication for them, where we can just give them more oxygen. It is somewhat forceful. It is somewhat uncomfortable for the patients a lot, because keep in mind, they're not oxygenating their body terribly well, so they're going to be somewhat hypoxic. This is a procedure that is very uncomfortable for these patients. So when you apply a mask, you're going to have to talk the patient through it. Tell them, this is an uncomfortable thing. I'm right here with you. We're going to work through it. Because what's happening to them, you're going to put this mask on them, and it's going to be similar to sticking your head out of a car window while you're driving at very high speeds. Super uncomfortable in the beginning, but the more oxygen they get, the better off they'll feel. And what I think is the most important thing, or the most effective thing for CPAP, is it has effectively reduced the need for intubation. We have all these patients who years ago would have COPD or asthma, would need to be intubated, would go up on the unit, get put on a ventilator, acquire ammonia or a VAP, and that really increases their morbidity and mortality. CPAP is a type of intervention that's really easy to do. BLS can do it, medics can do it, and it reduces their need for intubation. Generally speaking, it reduces their hospital stay as well. So CPAP is one of those interventions we want to use early and we want to use often. That's your 5-minute refresher. Be sure to like us on Facebook, Instagram, follow us on Twitter, subscribe on iTunes, and subscribe down below for YouTube. See you next time.